Welcome to the latest MS Here from the Experts webinar. These webinars help people better understand multiple sclerosis, highlights MS-related resources, plus provides tools and tips to navigate their MS journey with more knowledge and confidence. Thank you for joining us for today's broadcast. My name is Shauna McKinnon, and I'm your moderator for today's broadcast. I was diagnosed with MS in January of 1998, and I've been a volunteer with MS Canada and previously MS Society of Canada for about the same amount of time. MS Canada would like to acknowledge that we are on the unceded and ancestral territory of First Nations, Inuit, and Métis people across Canada. These nations have cared for this land from the oceans to the mountain peaks for thousands of years and continue to do so today. We thank them for the continuous care and for the opportunity to host this session today. At MS Canada, we are committed to learning from and working with Indigenous peoples to care for the land we all call home. Before we get started with our presentation, let's briefly go over a couple of housekeeping items. Your microphones have been muted. If you have a question, please type it into the chat box, and we'll try to get to as many questions as possible following the presentation. Please note that questions pertaining to specific personal situations likely cannot be answered in this type of venue, and we recommend contacting your personal MS healthcare team or perhaps contacting the MS Knowledge Network for those questions. The session is being recorded and will be available soon on our website in English under Informative Videos on MS, formerly called Archived Webinars, and on our YouTube channel. We're having difficulty with Facebook at the moment, but as soon as we get it working, it will be available also on Facebook. Also, please note that MS Canada does not approve, endorse, or recommend any specific product, therapy, or service, but instead provides information to assist individuals in making their own health and wellness decisions. The views and opinions expressed in this presentation are those of the speakers and may not necessarily reflect the views or positions of MS Canada. Since 1948, we at MS Canada have been proud to be part of a community of people living with MS, their families, friends, plus volunteers, donors, researchers, clinicians, and many more. Together, we have helped fund research, provide information, and support to people affected by MS, and we've taken a bold stance to advocate for changes that allow people living with MS to live full and inclusive lives. Our current strategic plan not only lays out the roadmap in our journey to create a world free of MS, but we hope it also provides inspiration for all in the MS community to connect and collaborate, so together we can advance treatment and care, enhance well-being, understand and halt disease progression, and prevent MS from happening. Please note that during this broadcast, a couple of pop-ups will appear. We ask that you respond to each. The anonymous information will help MS Canada better understand your experience and the impact it is having on the MS community. Now on to the presentation. Transitioning from pediatric to adult care for multiple sclerosis involves a gradual shift, emphasizing the young person's increasing independence in managing their health and active participation in decision-making. The transition requires collaboration between a variety of healthcare providers working with the young person and their family to ensure a supportive experience that fosters a sense of trust and familiarity. A successful transition to adult care is crucial for continuity of care, preventing treatment lapses, plus fostering the young person's self-management skills and confidence. Today, we're going to learn more about key aspects of the coordinated transition process with intention for good health outcomes and quality of life. Our experts both work at Sick Kids Hospital in Toronto. Dr. Anne Ye is a neurologist and Jolie Johnstone is a nurse practitioner. Welcome to both Dr. Ye and Jolie Johnstone.
I'd like to first start off by thanking the MS Canada for the opportunity and really for supporting the concepts of understanding what it means to be a person with MS, that journey is like, and how that can be improved through time. Today, what we're going to do is a chart seminar, first starting with the groundwork about pediatric MS and why we feel it's so important to think about issues around transition, and in particular talking about what makes pediatric MS so important to think about. I'm going to just advance my slides here. My disclosures are here, and these are my objectives. I'm going to start off by talking about structural and psychosocial consequences of pediatric onset MS, and to talk about factors that might influence the outcomes. And then specifically move on to discuss how a focus on transition and and health behaviors can help to improve outcomes. I'll move on to a story which all of you would be familiar with, having either experienced MS yourself or having had a loved one with MS, or maybe a child with MS. This is a typical that might come to us in clinic, who came to the emergency room at 14 years of age with difficult walking. And the astute emergency room physician performed an MRI scan of the brain and the spine after finding abnormal neurologic findings on examination. And what we see here is a very typical MRI of a very typical MRI, which makes making a diagnosis of MS very straightforward for a physician. But when a clinician like me, or like Jolie, or any of the other MS doctors that you might know sees this, what we see is the ability to make a very clear diagnosis. What we also are faced with, and what you as families are faced with, is the dilemma and the heart-wrenching question of what this means for the future. Because what does this mean for the future of a 14-year-old child? We know with MS that the problem is that of progressive injury. And we know also that with time, that progressive injury can lead to disability. But are there particular factors? When I'm going in that room to talk to families, and when you are being confronted by this diagnosis, what are the particular factors that one must consider in pediatric onset MS? And I promise you, this is very relevant to the concept of transition. Well, what we know is that with regards to pediatric onset MS, brain MRI scans that have been followed longitudinally have demonstrated that the injury that is incurred and the level of tissue loss through time is greater in pediatric MS patients than in those with adult onset MS. And further, we know as well that the developing brain, it is so important to consider the developing brain in this context, because we know that a hit with MS, or the diagnosis of MS, associates with a fall off in growth trajectory. We all understand that children grow through time, their bodies grow through time. Well, the brain undergoes similar growth and fall off in some areas. And if you look on the far right panel here, you'll see that the arrow on the light blue arrow and the peach colored the light blue line and the peach colored line represent the growth trajectory of children who are healthy without MS. And if you look further at the next arrow that I have here, the dark blue and the dark red, we see that those are children, boys and girls with MS, and this is their growth trajectory. And you can see that although they start off at the same place as healthy children, through time, the growth trajectory has fallen off. We can see this as well in different parts of the brain, in terms of the white matter, where we see a fall off of developmental trajectory within the white matter. And you'll remember that our brain is white matter and gray matter. The previous slide showed whole brain volume, and this is a focus on white matter. And we also know that there are ridges, so the back of the eye with the back of the eye, we can demonstrate changes that we see through the brain, in the brain. And we've shown that there are retinal changes through that time that mirror those that are seen within the brain. Okay. So what does this mean for disability? Well, what we know, and this is from a landmark study that was performed over 20 years ago, before the era of disease-modifying therapies. And I emphasize that because we're going to get to the point and discuss therapies and the importance of therapies for children. But we know that from this data, children who have onset of MS, usually in the mid-teens, will end up with irreversible disability by the time they're in their mid-30s. The adult population, this was seen in the 2007 cohort in the mid-40s. So 10 years younger than those with adult onset MS, although it takes longer to get to that point. What we also know, and this is a very nice study from the group in Sweden that have looked very carefully at individuals that had pediatric onset MS for many years. And what we see here is that this is a graph showing changes in a particular measure of cognition called the SDMT. And what this group demonstrated was that through time, individuals with pediatric onset MS, although they have some improvement or increases in their cognition for a few years, by the time they get to be 15 years out, their drop off in scores in this particular test, the SDMT, falls off more sharply than in the adult population. So the trajectory of change is affected differently in pediatric onset versus adult onset individuals. We learn too, as well with fatigue and depression, and all of you who are on the line are probably aware that fatigue and depression are very important issues in the lives of people with MS. And we found that in the children that we take care of as well. And as half of the kids we take care of have high levels of depressive symptoms. And this is the work of a postdoc is in my lab. And she demonstrated that through time, just like that trajectory you saw with the brain, that fatigue and depression worsen in children with MS. Okay, and this is just a slide demonstrating that. Okay, what about other long-term outcomes? Going back to the Swedish group that looked very carefully at long-term trajectories in individuals with pediatric onset MS, I want you to focus on that very dark-colored graph. The dark colors represent individuals with pediatric onset MS through time when they're 19 to 24, 25 to 34, 35 to 44, and 45 to 54. And the lighter colored box represents individuals with in a matched cohort, so healthy individuals in Sweden. And what you can see here is that by the time individuals in Sweden with pediatric onset MS got to 45 to 54 years of age, about 40% had zero earnings, meaning they were unemployed, compared to the regular reference cohort at a rate of less than 10%. There's similar information from the same study from the Swedish group that demonstrated a very high level of disability-related absenteeism from work, which was also illustrates socioeconomic challenges that individuals with pediatric onset MS have faced through time. I don't bring this to you to produce sadness or depression, but to think about hope and how we trajectory, because that's what we have changed. We have spent our careers doing, thinking of how we can change this trajectory, because we've observed that these are possibilities. So how can we change the trajectory? Well, we know that in the pediatric population, the use of any medication, anti-inflammatory medication or disease-modifying therapy, will predict lower levels of disability. And in fact, with a very large group, and this is a publication, the group called MS Base, together with the Italian registry, which evaluated thousands of pediatric onset MS. And the most important message here that I got from this study was that they did high efficacy therapies, slow disability worsening, so we can change that trajectory, but the use of any therapy at all made a difference to outcome. So The bottom line here is the use of therapy, and we've done other studies on physical activity and other lifestyle factors which we believe can change the trajectory and all of these other factors. We know that we have the potential to change the trajectory. But understanding how to transition to adulthood well is really important to changing the trajectory. And why is that? Because we know that if DMT has such a large effect on outcomes, we need to ensure that independence and self-management are part and parcel of what we help to our children to attain, the children we take care of to attain. Because we know that in adult populations, adherence is a major issue and has been a major issue, where about half prematurely discontinue therapy and consistently non-adherent with medications. And in the pediatric population, the numbers are similar. We looked at this question and we really tried to understand what health behaviors were important and how we could change health behaviors, and tried to evaluate the use of an electronic monitoring device and behavioral feedback, which is in the form of a counseling type of talk therapy called motivational interviewing. We tried to evaluate what effect that would have on adherence. And what we found was actually that the use of the electronic monitoring device and increased parental monitoring were associated with worse adherence. So watching closely and potentially not allowed to develop it in the absence of allowing people to develop independently might be either neutral or negative. One of our surprising findings. But we went on, and thinking about this, we went on to ask the question, well, what is it then that we can do to help improve health behaviors? And again, thinking about this concept of transition. What the children told us through interviews was that what they found to be most important was the ability to build and maintain habits. Build and maintain healthy habits, okay? In addition, in other work where we have been trying to understand health behaviors in the realm of physical activity, we found that social networks and efficacy are essential for health habit formation. And in fact, in this study of physical activity in children with MS, we found that physical activity, self-efficacy, and goal setting had the strongest associations in kids with MS, and were more strongly associated in MS than in other children. So we found that it was super important, and this has implications for our clinic, which Jolie is going to talk to you about. These associate with healthy behaviors. We went on to think about how we could put this in place and help kids develop healthy habits, and developed an app. And this is not focused on medication adherence. And you were talked about with the medication adherence, where we had had interviews and we had a device that sort of monitored kids. So we moved away from this concept of monitoring because that didn't seem to be the right approach, and went on to think, okay, how can we develop independent self-efficacy and goal setting in children? And this holds true for just physical activity, also for things like medication adherence and other health behaviors. With this app, what we found, and this is a very messy graph, but I will just to you that the most important thing, the secret sauce, seemed to be the involvement of a coach, and the coach helping kids to form goals and to think about health behaviors in a comprehensive way. We went on to perform analyses of the interviews that we had with the children, and found that the children told us that the coaching calls were a key ingredient, and that social connections, social support were essential keys to helping their independence and making these health behavior decisions, and to carry on with better health behaviors. More recently, and we're very grateful to the MS Society for supporting this, a graduate student who is a fledgling neurologist, Dr. Catherine Sawicka, has been conducting a study asking very specific questions about self-management, going back to this health behavior and the concept of transition. The bottom line with her work and the work of many others is that the development of self-management skills is key to moving from childhood to adulthood. So what is one to do? Jolie Johnson Doan, who is my part-time at the Hospital for Sick Children and a superb nurse practitioner and works with our teens all the time, is going to talk to you about the nuts and bolts of the transition process as we see it within the Hospital for Sick Children. But I'll first summarize what I shared with you just now. So just to summarize what I talked about, pediatric onset MS states with high levels of disease activity, high levels of mental health difficulties, potentially higher than in the adult population. There is a trajectory of worsening through time. It's important to think of these things because of the developing brain and social development that kids go through this time. But this is something that can be changed. We need careful thought to transition with a focus on behaviors. And really, things like social efficacy, social networks, and self-management are key to success in this area. Now I'm going to turn to Jolie now. I'm just going to share a picture of my wonderful team and acknowledgements to all the people that have done this work, and then move on to Jolie for her discussion of the nuts and bolts of transition. Thank you.
Thank you so much, Anne, for that great overview. So that was wonderful, and we're going to be talking a little bit more about self-efficacy, self-management in the next part. So health transition in youth with multiple sclerosis. So it's a tricky time. A lot of times this is happening at the same time that other transitions are happening. Kids are moving from secondary to post-secondary school. They may be moving from a home residence to a school residence, or geographical areas if they're moving to a different province for school. So it's a very tumultuous time, and in a lot of cases, especially in our institution, it happens at 18, which is when some of these other things are occurring. So health transition usually involves moving from one center or hospital to another. In some cases, the MS clinic is within one institution. In our institution, it involves moving from Sick Kids Paediatric Center to an adult center. And the youth, usually require support for building these, self-efficacy skills, navigating this new systems, meeting new doctors, creating new relationships and new rapport. And so, our goal is to try to talk a bit about that, to come up with some strategies to support our teens. So the one thing we know is that transition is more challenging in youth with MS and other chronic health conditions. Young adults with chronic illness may be less likely to pursue post-secondary education. They may be less likely to participate in social activities or in leisure activities or sports. And they might likely be more likely to have higher unemployment rates or rely on their families for living arrangements or for care and help getting to their appointments. We also know that they experience more depression and mental health issues. So what is a health transition? So a health transition is a purposeful, planned movement of adolescents or young adults with chronic physical or medical conditions from a child-centered system to an adult-oriented healthcare system. So a transition is more of a continuum. It's not a one-time transfer that happens. It is on a continuum, and some children are ready to start that continuum at 12 or 13 years old, whereas other teens maybe need to be a little bit older to start engaging in some of those transition movements. So transition is not an administrative transfer of care. So a transfer of care represents a one-time event where the responsibility is shifted or handed over to a new team. So an example of this could be if a patient is brought in from a northern hospital and is transferred to sick kids, the care team gives report for the patient, the responsibility is handed over to sick kids, and the therapeutic relationship ends or is paused at that other hospital, and we assume care. So that is not what's happening during a transition. We want there to be a purposeful movement that can go backwards and forwards as the adolescent needs. So why is it important to have a successful transition? Well, negative transition care experiences may contribute to caregiver or family burden or distress for the adolescent. A lot of youth with complex medical needs, or if they have cognitive issues, they need their family or other caregivers to retain key supportive roles during and following that transition. So it's really important that families and partners or friends or whoever the adolescent sees as a supportive person is involved in the process. And because if they lack the capacity to consent or make healthcare decisions, it's really important that other supportive people are involved. So the healthcare transition involves many different variables. So these are a few that we've talked about already. There's obviously patient factors and parent factors. So these are the two things that we think of when thinking about moving families. But the other thing, like Dr. Ye brought up, was that, medication adherence or the transfer of medication under parents' drug coverage, and then that may be ceasing as the child becomes 18 or if they go on to a university. The other thing that can happen is that children go away to school, or they may go on to be employed and have different coverage and different variables that they may be not able to take off work like they could before when their parents were bringing them to their appointments. So all of these things can come into play. And then there can be system barriers, again, with adolescents trying to get to their health provider appointments without their parents. So these are all things that need to be taken into consideration when you're talking and beginning the transition with the child and the family, talking about, what's that going to look like? Where is the child going to be living? Who's going to be taking them to their appointments? Who's going to be coming with them? And all of those also tie into the social determinants of health as far as, finances, funding for things, funding for medication. So these are all different variables that we have to talk about and explore when we start the transition process. So the Canadian Paediatric Society's got a fantastic position statement around transition. They've got an excellent article with some great strategies in this. And so, we always encourage adults and other providers to look at this, because it really is a great resource, not just for children with MS, but for any children with medically complex healthcare needs. And some of the key things from their recommendations we're going to talk about. One of the things that I think is really important is flexibility in the transition. So at a lot of institutes, there is a time sort of cutoff, like there may be an age cutoff of 18 or 19 years. And what the CPS recommends is that actually there should be some flexibility with this sort of time cutoff point to align with current adolescent growth patterns, and understanding that neurodevelopment and emotional regulation and emotional maturity is very different for different individuals, especially if those children have cognitive or mental health issues. They may need longer. It may not be ready to transition at 17 and a half. And so one of the things that I would like to advocate for, and we'd like to advocate for, is having some flexibility to have patients stay in the pediatric system if it's needed, a little bit longer, just to support it being a successful transition. So in this type of model, the youth would be given increasing levels of responsibility and information, and we would still try to start that process early. But if there are youth who are identified as needing a little bit more time, that they would have that. And so that's one of the key elements of the statement that I really like. The other thing that the statement goes over is the core principles of transition planning. And so these are 5 great principles that we'll go into in a little bit of detail. The first one being starting early. So, if the child is aiming to transition out of the pediatric center at 18 years old, you don't want to be starting your transition planning at 17 years and 9 months, right? We want to start talking about this, planning when the child is, 15 or 16, and starting some of these things long before the patient is actually moving to the adult system. So these could be certain things like, the child knowing their diagnosis, the child knowing the name of their medication, knowing how they take their medication, how they store their medication. And simple things like just being able to provide their own health history. So, we're big advocates of talking to children and having them give us their history of how they're feeling. And so we try to direct our conversations to teens and say, you have to let us know. You're the expert on your body. What's going on with you, right? And letting the child or adolescent sort of take the lead on talking about their health issues. So starting early, could mean 12 or 13 for some children, or for other adolescents, it could be 14 or 15. But starting that dialogue and having them have an awareness about their health and their medicines, and being able to say what they are without the parents being in the background to give them that information. One of the other core principles is creating an individualized plan. So obviously, lots of our teams are, bright. They know their medications. They have, a very good plan for going on to university, and those patients, sometimes don't need a lot of direction and support. Whereas other patients, we have to start thinking about that, plan a little bit earlier and putting in specific things related to them. Like if the child is moving to another province for school, and what's that going to look like? We have to find a provider. We have to find how they're going to get their medications. And so it involves a little bit more legwork. And so creating an individualized plan based on the patient and the family. The other big thing we want to do is providing that support before transition. So starting the dialogues, letting them know a little bit about the adult team, describing what the environment's going to be like, describing what moving to an adult system is going to be like, giving them the background around, what's going to happen before they actually move to the adult center. And then another big element is communication between the pediatrician and the adult providers. And so we send over basically a package to the adult provider, which provides the health history of that context. But with some of our patients, especially if they're particularly complex, we'll reach out and have a conversation, or have an email, or even have a case discussion if there's very complex patients where we need to have a discussion with the adult provider to give them societal, social backgrounds or other histories. And then something that we really support is providing support after the transition. So once the child has met the adult team, we then have a post, meeting, either in person or virtually, just to make sure that the rapport, went well, that they had a good appointment, that, if there's any concerns, they had any questions. And so we always book, sort of a final appointment, and just to address if there are any challenges and address those early on. So which transition interventions are effective? So we know that there are tools and different resources that have been created that can help, and we're going to talk a little bit about some of those that we've used or we recommend. And there's limited evidence to support any single effective transition intervention. Again, a lot of these things can be caregiver based. Some patients really want to use technology based things like apps or have their information delivered electronically, whereas other parents want to fill out questionnaires on paper and prefer to have paper resources. So again, in creating that individualized plan, we're going to honor whatever is going to support the family. So some of the strategies that have been created are, like I said, apps, care navigators. One thing that is amazing, if you can have it, is a joint pediatric adult clinic, and this is where the adult provider actually comes to the pediatric center and they have a transition clinic. I've worked in another program in rheumatology where we had this, and it was great because we would book all of the patients that would be transitioning to the clinic so they could meet the provider, and it was a really nice way to sort of start the therapeutic relationship, and for them, the teen and the parent, to meet the new adult provider. So Sick Kids has some resources on our About Kids Health website, which is a great website that's got loads of information. It's very nicely in multiple languages, which is great. They have this learning hub, which has got some links to a few different resources. One of the ones that I think is great is this 3-sentence healthcare summary. And this is not just for kids who are transitioning. This is something that, even a 12-year-old or 13-year-old child could start, or even younger, could start learning. And basically, you're going to teach the child, this 3 sentences, which is their age, their diagnosis, and a brief health history. 2, the treatment plan so far. And 3, any questions. So this could look like, a teen saying, "Hi, my name is Jamie. I'm 17 years old. I have MS. I take Plegridy medication. My last MS relapse was in January 2021 due to vertigo and leg weakness. And today, I'm wondering if I'm allowed to try out for track and field." So perfect little summary that, allows the child to be empowered and to ask their questions or concerns during the visit, not necessarily just with transition, but at any of the health appointments, but also can be used during transition times too. Another great resource is this My Transition app, which was created by our colleagues at McMaster Children's Hospital. And this is, again, a health transition app for adolescents with any health conditions, so not specific to MS. And it's got some great resources, including a calendar, which can keep track of your appointments or infusions or injections. So, the child can put in their different injection medication dates or when their infusions are due. There's some tips to improve transition. And one of the great things is this transition scale, which basically the teen can take, and then it can show where there may be some opportunities for support, and it can be taken a couple of different times. So the transition Q scale is also in a paper version, again, developed by McMaster Children's Hospital. And it's got some great questions that, can stimulate information around, where the child's at from a self-management standpoint, right? So the first question is, I can answer doctors or nurses' questions, right? Never, sometimes, always, I'm in charge of taking my medications. And so this is a skill that can be completed at different points during the transition process, so that if we are identifying some of those zeros or never, we can speak with the teen and say, like, hey, I saw that you filled this out about your medications. Like, do we need to do some, teaching or education around medications? And the last one is this Got Transition website, which has got some great resources too. So in wrapping up, want to start the transition discussion early, creating an individual plan, transitioning, assessing that before the transition occurs, using some of the resources that we've talked about, and providing support after the transition. And that wraps up my part. Thanks.
Okay, well, thank you very much, Dr. Ye and Jolie, for your informative presentations. Lots of stuff in there that I had not seen before or known about or given a thought to because I was an adult when my MS. But I do have one question that came up. My own curiosity, with greater cognitive impairment and faster time to disability in pediatric onset of MS, are rehabilitative or adaptive therapies and occupational therapies, are they encouraged? Do they work for pediatric onset?
What an important question, Shauna, and thank you so much for asking that. So one of the things that we like to think about is catching things before they go downhill, right? And really, when you look at that downward trajectory, our own position as carers of people that are early on in the disease course and are in their young years is to say, what can we do to prevent that downward trajectory? So we actually have physical activity, a physical activity intervention that is intended to improve outcomes. These are more mental health outcomes, but we know that physical activity has been associated with all kinds of other benefits, including cognitive benefits. The other thing that's been evaluated in large groups, but appears to be a benefit is this concept of cognitive rehabilitation. And this may be what you were referring to, Shauna. So there have been we did a small pilot study. It was actually run by Christine Till, who's at York University, evaluating kids looking at cognitive rehabilitation. They seem to tolerate it very well, but it takes a lot of time. So yes, there is a hope to involve kids in some of these even pre-rehabilitation types of interventions. And yes, we think they could make a difference.
Okay, so from our audience, we have a few questions as well. Addressing mental health issues for anybody living with a chronic disease is crucial to good health outcomes and quality of life. What screening and treatment needs should be built into healthcare planning for individuals with MS who are transitioning from childhood to adulthood care?
Oh, such an important question. And you have just hit things to something near and dear to both of our hearts, because this is what we see every day. So as I mentioned earlier, about a third to half of the kids that we take care of have high levels of depressive symptoms and also have fatigue. And so we actually do questionnaires that focus on these questions, these issues. And the other thing that we've instituted recently at the Hospital for Sick Children is a global screening of children in different specialty areas, in which these issues are identified through a simple questionnaire. And what makes it a little different from the screening questionnaires we had been doing previously is that we receive an alert as to what the scores are, regardless of what the scores are, and a notification and a I guess directive to actually discuss this. Drives us as clinicians to talk to families about this, families and children. In terms of put in place, so some of our interventions that we're looking at are intended in particular to counteract the issues around the mental health issues, and those include physical activity interventions. We hope that is different from the perspective of transitioning from the pediatric to the adult population and handing those things over. What we hope going on the theme of transition, is to prepare kids and to identify this early so that we have a plan in place before they move to the adult world, because we know that it can be more challenging once they arrive in the adult world. There's so much else going on when they move from being, at home with their parents to on their own. I hope that answers that question. I don't know, Jolie, do you have other things to add?
Yeah, no, I just would only say too that we really try to support the teens, networking and supporting each other. We do put on, family events. We've put on events with the adult hospital too, to try to, have people network and support one another. And we also had an online teen support group that we were doing. And so those are some of the ways that we try to support, the teens as well.
Okay, yeah, I was wondering and just about the peer support.
Pardon? To highlight, that peer support is so important. Just to highlight what Jolie had said, when we've asked kids the question, what we found, and I didn't share some of our other work on social networks, we've been very interested in social support and social networks with our own population to understand what we can do to help kids. And it turns out that seems to be the important elements that kids point out to us is the presence of social support and particular social networks. So whether it's through the groups that Jolie has developed and runs, or through school, or some of the things that we're doing with our interventions, where we're trying to get kids to interact in our physical activity intervention, we think those are crucial and key.
Okay, on to the next question. Regarding flexibility when transitioning to adult care, what does the process look like when you're advocating for an individual to stay in pediatric care?
Do you want me to address that one, Jolie?
Sure, yeah.
Or do you want to? Because it's actually challenging.
It's difficult. So we can, though, at Sick Kids, the transition age at Sick Kids is 18. We do have the ability in special cases to request, an extension of that if there are extenuating circumstances. And this would be if the child has a really unique or complex medical condition, or if just they need that extra little bit of, social time. But most of the time they do want us to
elaborate.
Try to move.
I'll elaborate a little on this, and this has to do with the healthcare system here more than anything else, and so it's very different place to place. In the United American Academy of Pediatrics has clearly recognized that the pediatric age group is 25 or under, as Jill pointed out. Within our own hospital, the cutoff age is 18. And we need to be very strong advocates in situations where we think it's necessary for children to stay with us, and we have to ask for that permission every 6 months. And so our own institution has a very strong policy in place that necessitates our advocating periodically for this. So I want to say that Jolie and I will work together to change the system, but our system is actually quite well defined. Now, in some cases, when there are necessary medications being administered, when we have kids on trial, and when we have other things that are unobtainable in the adult population, we have a very strong argument to say yes to that. So I want to just emphasize that we want to accommodate, but our hospital is quite strict.
Okay. Well, one more question. You want to help those transitioning into adults with MS by teaching them to take an active role, if not the lead, in managing their own healthcare and decision-making. How can clinicians support the family and overcome issues related to children and youth not taking their prescribed medications properly, or is that a big issue?
So adherence is something that that we thought about a lot. Adherence or the taking medication regularly. So a large group of kids, it is an issue with some children, and it can wax and wane. I think Jolie can talk more to the very close relationship that she's developed with a lot of the teens, and there can be many reasons for kids not wanting to take their medications. One of the privileges that we have is actually having Jolie to work closely with teens. We found in the previous clinic that I worked at, we did have very strong, like a strong support network, but we didn't have a Jolie. And I think when kids have problems, they want someone to talk to other than their parents sometimes, and they need someone that is supportive and knowledgeable about the medication that can take the fear away of whether it's they're mad about having MS, which can be people experience, but also they might be scared of side effects. They're scared of some of the of what their medications might be doing to their bodies. Jolie, I think that you should talk a little bit more about this because you work so closely with the children.
Yeah, thanks, Anne. Yeah, so I mean, it is difficult, when we're faced with these, children. They like, I feel good. I don't need to take this. They have this they're invincible, right? The teen is like, that's not going to happen to me. So it can be challenging using the motivational interviewing strategies, which Dr. Ye talked a little bit about. Talking about like, what do you want to do in your future? Or you want to do this, and you want to travel, and like, how do you see that fitting if you're not well, or if you have a disability, right? So sometimes just really, like Dr. was saying, getting to know the child, speaking with them, talking to them about what their goals are, what they want their life to look like, and then well, how would that be impacted if you didn't take medicine and then you ended up having to use a walker? How would you be able to travel Asia or do some of these things? So those are some of the, the discussions I have with them. I think when we've had some of our adolescents who have transitioned out come to our online peer groups that we do, the teens love meeting other older adolescents, and they ask them questions like, how was it when you went to university, and what happened, and tell us all about it. And so having great leaders, like patients who are leaders, come back and talk to our teens, and is also very empowering. And whenever we've done patient events, they say, my favorite part was when, that girl Sydney, who was 22, came and talked about her experience, and that was so wonderful for me. I also had another experience yesterday where I was doing a call with a patient, and he's 12, and his mom was supposed to join, but she was having network issues. So I said, let's just do the call. We ended up doing the whole appointment, and he was a superstar. And gave his health history. We did the whole appointment. The mom sent me this email afterwards. I'm so sorry, I couldn't join. And I said, you know what? He did amazing. And I told a great job he did. And so just empowering the child. I'm like, you just did that whole appointment all by yourself, buddy. Like, you don't even need your parent being there. And so I just gave him, the mom was all apologetic. I'm like, he aced it. He didn't even need you there. He was awesome. And so just giving that feedback, I think he was like, yeah, I kind of did it on my own. And and so just doing that, like, you got this, like, you don't need, mom doesn't need to answer, you can tell us. So we're always doing that at our appointments, right? Trying to engage the teen, so I think that, we try to like start that empowerment, start those self-efficacy things early on.
Excellent. Well, we've come to the end of our time for questions. So I want to thank you, Dr. Ye and Jolie Johnstone. Sorry. I want to make your name French for some reason. Thank you for your participation today. As we wrap up the broadcast, we do want to remind everybody that you can connect with the MS Knowledge Network, which is staffed by trained navigators who provide consistent, quality information and support. Connect by phone, email, or live chat through the MS Canada website. Navigators are available Monday to Friday from 8 a.m. to 8 p.m. Eastern Time, and they can provide assistance in both English and French. We'd like you to be part of the MS community and encourage you to get involved with our programs, services, events, government relations, and volunteer opportunities. Together we can take action to create a future free of MS. To find out how you can take action, just check out the website mscanada.ca. If you have questions about any of our education activities, you can reach out to the education team by email to education@mscanada.ca. On behalf of MS Canada, thanks for tuning in for today's webinar. Good night.